for you guys, including free dinner. We have about 20 amazing speakers. Our guest speakers, Howie Mell, who we're bringing in, and it will be a purely evidence-based conference, mostly all medical. Amazing speakers, and you need to sign up at our fellowship spot, www.emsfellowship.com. Make sure you sign up, and I'm going to post some stuff about the parking garage. I guess I'll just say it now. You're parking right across the street in the military parking garage. It's called the Newark, and there's an underground tunnel into the ballroom, and we're in the Tri-State Ballroom at the Robert Treat Hotel, May 22nd. 4 to 4:45 will be a special award ceremony. We're giving lots of plaques out. Next year we'll do it to EMS. This year, since it's really our first one that we're advertising, we're doing it to the police. So we'll have an award ceremony for the Port Authority Police, for the Newark Police, for the State Police, and for the Corrections Department with police officers who did something heroic in saving somebody's life. And next year we'll do EMS folks. But every dollar we make, we're going to pay for somebody to go to paramedic school for free, but you have to show up to the conference, and then you submit an essay to us, and we'll discuss everything at the conference, how you're going to, how we'll give you the money, etc. We have several sponsors, so make sure you visit the sponsor tables at the conference as well. And then we're also going to give you a little brochure with everybody's email, because we'll have a limited time for questions. So we'll give you everybody's email so you can ask them questions if there's something you agree or don't agree. But we're going to talk about stuff that'd be very hard, or if not impossible, to read in a book, right? And we all know that literature runs about the textbooks run about 3 to 10 years behind the current way of thinking. So we're going to present to you the latest, greatest information. I've seen most all of the lectures so far, and they all look fantastic. So you're going to be impressed. Make sure you get there right on time, though, so you can get some food and you can don't walk in the middle of the award ceremony. So that's that. Also, I want to say that we are, the next day, if anybody's interested, I will get invited to speak for their EMS week at Mountainside Hospital. So I will be there the next day. So a shout out to them. A shout out to our police. A shout out to, I guess we're getting right now about 1,200 viewers. So make sure you like us so everybody can know we're live right now. And we're getting about 7,000 views per week. So that's pretty impressive. Lastly, I just got notified that we are on MRAP. So our article that we published on redosing of naloxone in the pre-hospital setting, the largest and first database ever. But I think we had, 2,500 people in the study. We show that 9% of people need a second dose of naloxone, 2% need a third dose of naloxone, and if you get a GCS of 15, nobody needed to be redosed. Although we all know that GCS is complete garbage and we shouldn't be using it because the science is totally against it. All right, so we're going to get started. Again, make sure you like us. We're going to go right into interesting cases. So who wants to start?
You have pre-hospital?
Who had the salicylate one?
That was an ED.
Yeah,
one.
well, I had.
Yeah, we can do the ED.
It was actually more than one salicylate overdose recently. Essentially, the first one, it was a man found unconscious, unresponsive. There was a little bit of alcohol on board, and essentially, he was completely altered. Usually, he's able to talk. The son came in with him. Met EMS at the door, and the one thing that was not conveyed to us at the time, like in the emergency room, was that there was 2 empty bottles of aspirin next to him. That was only later found out maybe an hour after he had arrived to the hospital. So that's why, especially for our pre-hospital providers, the scene safety and also the scene makes a big difference, because that one little detail makes all the difference. You have a person who comes in altered, it seems like an alcohol overdose, which there was alcohol on board, but for me, he was diaphoretic, he was tachypnic, and it just wasn't fitting with just alcohol alone. And then when the son kind of brought up that, there were just 2 empty bottles of aspirin laying next to him, that really helped kind of solidify the diagnosis. The other case was similar. This was a much different presentation. It was a 21-year-old female who went to CVS, bought 2 bottles of aspirin, and then chugged both bottles, and then called 911 and said, "I just chugged 2." So that was a little bit easier. I don't know about you guys, but for me, if it's already been over 2 hours, I usually don't give activated charcoal for these patients because it's already passed. I received the patient after 4 or 5 hours, so I hadn't actually started anything, and we know that the tinnitus is a big thing, but that you can get that at therapeutic doses. The tachypnea is another thing. You don't always see diaphoresis except for larger overdoses. And then these patients may need ICU level of care as well as dialysis. So, and then what's the big things to look out for? You want to look at your EKG. Make sure there's no QT prolongation, no QRS widening.
And your ABG.
And your ABG, yes, you want to see what their stats are. And that's why these guys are kind of tachypnea, they're blowing off. And the therapy is really start bicarb.
So we all know that the classic findings, that the textbook answers, these people get a respiratory alkalosis and a metabolic acidosis, right? Is it
It's a
anion
mixed
gap or
picture.
not anion gap? Anybody remember?
Anion gap. Salicylate is an
It's the
anion gap,
S.
metabolic
Right, so
acidosis.
it's anion gap metabolic acidosis. And there's two things. There's Tylenol and salicylates or aspirin, right? And salicylates all look sick as can be, and Tylenol all looks perfect, right? And that's how you tell the difference just clinically. Tylenol has a clear phase. The second phase typically where you're completely asymptomatic, and even first you have minimal symptoms. So Tylenol overdoses can be terrible. Tylenol overdoses are usually, depends upon whose article you believe, either 140 or 150 mg per kg is a toxic dose of Tylenol. So take your weight, divide by 2.2, multiply it by about 140, and that's how much Tylenol you can take without having a problem. So when somebody says, can I take a third extra strength Tylenol? The answer is yes, take a fourth, right? Now that's a one-time dose. It's very different from a chronic Tylenol overdose because the bottle will say take 4 grams, but that's a very conservative number by the FDA. United Kingdom and other countries have actually made that much, much higher than we do.
I think we used to have it at 6 grams per day, and then they lowered it to 4 grams in the last couple of years.
Yeah, but if you look, I mean, therapeutic range of Tylenol is 10 to 20 milligrams per deciliter. We normally don't check your therapeutic range unless we think if you're overdosed. But if you look in people who take 15 or 20 milligrams per kilogram of Tylenol, they almost never get therapeutic. If you look at kids who get regular Tylenol, they probably need anywhere. There was one big study which showed they need 45 mg per kg to get therapeutic levels of Tylenol in their body. So we underdose Tylenol all the time. Again, one-time dose is different from a chronic, taking it every 6 hours or every 4 hours. Then probably 4 grams on a 24-hour period is probably a reasonable dose, but it's still very conservative. And salicylates, the idea is to alkalize the urine, right? As opposed to tricyclics, where the idea is to alkalize the serum. The only way to really alkalize the serum is to intubate somebody and blow them off. And the only real way to alkalize the urine is one, you pray they're not hyperkalemic, right? Because if you're hyperkalemic, it's pretty much impossible to alkalize your urine. And 2, you give them bicarb, and bicarb will alkalize your urine as long as your potassium's in normal range, so you have the potassium at the same time. But salicylate overdoses can die, right? I remember a case of a guy in jail, a paramedic here responded, and the guy's blood pressure was 50 when they showed up, and they couldn't figure out what was wrong with the guy, all this stuff, and as it turned out, he overdosed on salicylate, so we never figured it out before his post. And luckily, somebody wanted to do a post to help figure it out. But we don't see that much salicylate. I mean, Pat, how often do you see a salicylate overdose?
I can't remember the last one I've had.
Yeah.
It's been forever.
Half the reason why is people aren't taking aspirin for pain.
Right.
Whereas before it was just analogous to like even taking Tylenol or ibuprofen. If someone had pain, they take they pop an aspirin, and now we're not really seeing that.
Right.
Probably goes back to the Rise syndrome things in the
Yeah.
80s when they really took aspirin off of anybody's radar except for ACS.
Right.
Yeah, so Rye syndrome is for the kids. They don't want to give aspirin to them because of that.
Right.
Also,
or things with aspirin in it. Like I see this mistake made. They make it like in camp, right? You guys know this. Like they have bottles of like Pepto-Bismol with
Pepto-Bismol,
aspirin in it for kids, and that's wrong. Throw away your Pepto-Bismol because you shouldn't be giving that to children because that's got aspirin in it, and that can cause Rye syndrome.
One of the biggest pearls for aspirin overdoses is if you have to take someone's airway, I mean, there's two major issues. Is one, if you try to RSI someone and paralyze them, they're gonna rest on you because they're so tachypnic. You have to match that respiratory rate.
Right.
So
That's a really good point.
even when you sedate them, you need to start ventilating them. These are the patients you actually have to bag, and you have to bag them at the rate that they were breathing prior to you sedating them. And if you paralyze them, you better keep bagging them at the rate because you need them continuously blow off. And if you don't, as soon as you paralyze them, even that 1 minute of phase or 2 minutes or however that long that phase is where they're paralyzed, they're retaining. They can become so profoundly acidotic that they arrest.
Right.
And this is commonly seen. That's the biggest mistake you can make.
Right.
So one, don't intubate them and push them as far as you can. And if you ultimately have to take their air away, you don't really want to paralyze them. If you do, or if you sedate them even, you want to match their respiratory rate when you ventilate them. And then once you intubate them, again, the respiratory rate has to be very high so you can blow them off.
Right.
And you really want to use, again, you can use your end-tidal CO2 to kind of help manage that as well. But that's huge. With intubations, that's one of the things that we always talk about once you intubate someone, vent management and vent management in aspirin overdose is completely different than any other ball game.
So because we always talk about the bag of death and how bad it is to
Absolutely.
hyperventilate somebody. So here's like an exception.
Right.
And so when somebody is tachypnic or they have respiratory alkalosis from any cause, you need to match that. That's why it's another reason why our cardiac arrest rates go up when you intubate certain types of people, especially ones who are in respiratory alkalosis. I mean, for that matter, when I think of respiratory alkalosis, I think of anybody like who has maybe PE. It depends. Anybody who's tachypnic is at risk for metabolic alkalosis.
Sure. I mean, one thing is like when you have like acute ingestion, like someone takes like 60 tablets, do you really see this common board Bezoar formation? Or when do you see this Bezoar formation that we always look for and we're eager to see? Does that happen in acute ingestions or even chronic ingestions? Or how many times I've never seen it?
Right.
It's
So
only
what
a board question. So the question becomes is there a benefit in giving activated charcoal or even like even irrigating their bowel when you talk about like some significant ingestion when you're thinking of like this Bezoar phenomenon that you can have?
We're
That's classic
doing
with
hold on
aspirin.
irrigation, right?
Yeah.
For those of you who don't know what Bezoar is, it's basically just like a big ball of medicine. So it's continuously giving you more aspirin as you go along. Actually, this was a concern for one of the cases. The initial level was 600, and I repeated it in an hour, and it went up to 650. So they wanted me, and this was maybe 6-7 hours after ingestion. So they wanted me to give the activated charcoal for that reason.
And
this whole Bezoar.
Yeah, and I just went to a toxicology literature update conference last month where this specifically came up as salicylate. I actually have my notes from the conference about salicylates because this was such a hot topic because most other things you have some time you can do okay with. Salicylates, like Dr. Merlin said, these patients are sick. I mean, they are sick. And the debate was, we came up with this random, if it's been more than 2 hours, don't give them charcoal. And that doesn't, some of the literature out there is saying, well, there's no harm to giving it, especially if the patient's awake. They can protect their airway, they can talk, they're not altered.
So they look great.
Well, as I said, if the patient can pretty much, if you're comfortable giving them something to drink and they can do it, do it. I'm not sure how altered your patient was. I mean, were they cooperative enough to be able to drink something?
So the first patient was completely altered. The second patient was like I was going to send her to Pez. I wasn't even going to work her up. I was just like, get the levels, and then when it's negative, send her over. And then the level came back at 600. I was like, oh.
Yeah. So
Okay, then.
Can't
I mean, essentially they said, so I mean, if the patient's awake, great. The other thing is that if it does get to the point where you need to intubate them for whatever reason, like Tagore said, try to keep dragging on as long as you possibly can to avoid intubating them. But if you do, if you're going to give them one tube, give them another tube, and go ahead and probably at that point either do
After intubation.
after intubation, you can go ahead and actually do a gastric lavage.
Yeah,
try to
true.
get that out.
Have any of you ever done that?
I've done it.
I did it on the mannequin when I was at the conference.
I did it for a patient with gastric outlet obstruction, not necessarily for someone with, acute overdose.
Yeah.
And it's a garden hose.
I mean,
Knee
yeah.
wall, that's knee wall too.
Yeah.
Yeah,
I mean,
Yeah.
I did
It's a
knee wall
40
when I
French
was
too.
when I was a resident, and did I do it as an attending? I don't think I did.
hard to
I
pull
don't
that
remember, but as a
trigger.
resident, I definitely did it on
I
some
did
of
it
my
as a
rotations
resident,
because
yeah.
everybody was doing it, right? It wasn't weird. They
Yeah.
put, I mean, I remember when the nurses used to put EWAL tubes in people,
I mean-
and they would take people who were wide awake and shove EWAL tubes in their mouth,
Mm-hmm.
and sometimes they would shove it in their nose and rip apart their turbinates, and then we have people who are
Through their nose.
hypercoagulable,
Yeah.
and they would put in EWAL tubes.
Yeah.
And the idea was, you know, you're putting in, charcoal, and then you're you're lavaging them. So we'll just separate out. You're lavaging them. But then there were some chromium studies which showed that if you actually, although you get some pills out, so you think it's a good idea, you actually push a bunch of pills down to duodenum. So there were some chromium labeling studies where you push more tubes.
Well, apparently that's where all your absorption is.
So they said there was conflicting evidence on it, but pretty much they said that if you're going to put one tube, go ahead and put the other tube and do the lavage. If it's something
It's a fresh overdose.
If it's a fresh overdose and it's something that is that could potentially be something that's small enough, a pill small enough you could get back, or something that is very highly toxic in terms of a small amount of pills, a handful of pills can kill you, which I know that's going to be one of the topics at the conference is kind of a handful of pills can kill you. So something like that has a very lethal toxic range and a low dose, try to get that out as much as you can, especially if the pill is big enough, is small enough to be able to come out. But if it's a huge pill that you're not going to be able to get a bunch out through the tube, it doesn't make sense to
And
do.
just to be clear, we're not saying never intubate these people. We're saying hold off as long as you can, because intubation increases mortality in these patients. So these patients, I would let ride on lower sats.
Even
you know.
altered.
Huh?
Even altered.
Yeah.
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 Yeah, so let it ride on lower sats, even
Right.
altered. Do not rush to intubate these patients.
Right.
And then
Well, also, when you intubate them, high respiratory rates, try to match what they're at, and also just make sure you have enough expiration.
And this
Because-
is the problem giving charcoal, by
yeah.
the way, because you give charcoal and then they became altered, they're going to aspirate that charcoal, and that is a terrible, terrible outcome.
yeah.
I mean, EWAL used to be the rage 15 years ago. I mean, everybody got EWAL'd, and they got EWAL'd awake. And I mean, it's just a sight to see. And I mean, but you could see it. I mean, acute ingestions, as soon as they start pumping the syringe, you would see, as soon as they're pumping that vacuum right back out, you're seeing tablets come out.
And you
It
feel
was
good.
effective. It feels
Like,
good.
You feel good, but
I mean,
more pills are being pushed out into the
absolutely,
lung and getting really
absolutely.
absorbed.
And
the
that's kind of
problem.
what you're not seeing, right?
There's studies showing, though, that there are pills in the stomach up to 24 hours after an ingestion and massive ingestions.
Right.
So that's why whenever I call tox, they're no longer recommending EWAL as first line, but they are recommending charcoal. I
Sure,
find
right.
longer and longer and longer, up to
Yeah.
24 hours after. So
Right.
But do you want them to drink it, or would you rather just put a
Then the question is-
OGNG?
right.
What
Bolus
overdoses
it.
need a second dose of charcoal?
So you want gut dialysis
Well,
with
you guys
certain
should know
like
this because you just took boards.
carbamazepine.
All right, carbamazepines, that's a good answer. What else?
What else can you get gut dialysis with? Any toxicologists out there?
So carbamazepine is probably, and the other one's probably theophylline.
Theophylline, right.
Yeah.
So the two drugs that need a second dose of activated charcoal would be carbamazepine, and the other name for that is Tegretol. Right, so Tegretol, which we give for seizures, but we also give Tegretol for, what's the other thing we give Tegretol for?
I don't think I've ever used Tegretol in my life.
For trigeminal neuralgia.
Oh, right.
Oh, yeah.
What's the other name for trigeminal neuralgia?
Painful face syndrome.
So, Tic-Talaroo.
Particular.
And how do patients present with it?
Just lightning-like pain.
Yeah, severe
Just
lighting
severe
through
pain.
their eye or through parts of their face, but like severe pain, like they're screaming, right? And there's a surgery for that too, but you can give Tegretol and supposedly like it works chronically.
And no one knows why.
But it's a neurosurgical procedure you can have for people
They
with
could do
severe
radio
facial
surgery or
pain.
something.
What?
They do radio surgery.
Yeah. All right, anything else with that? Or what else did you learn?
So the other things is, this is something I didn't know about and I'd never heard about until the conference, was patients with acid with salicylate toxicity can potentially have neuroglycopenia. So essentially what it's saying is these patients, they may be altered, they may have a normal blood sugar,
Just
but
give them glucose.
you need to give them D50. You've got to give them glucose because the metabolic demand in the brain of glucose is so high. In these patients, they have to have more glucose. So,
So-
pretty much empirically treat salicylate toxicity with D50.
So why
In the setting
D50
of
not D10
euglycemia.
or D5?
Pretty much.
making that up. They don't have enough patients.
They don't. Yeah, I said they
did.
did. They pretty much said D50 is because that's what is the easiest to get, And they really don't have any evidence on why one versus the other. I know we're looking at the D10, D50, so,
Right.
but they pretty much said dextrose. You want to get some kind of dextrose.
Because we're
to that
believers in
patient.
never giving D50, right?
Yeah, so-
Nobody should ever get D50. It's
So I
always-
tried to give D10 for this patient, the one of the patients I had, and it was like Meditech. I couldn't figure it out, so I just gave D50.
Yeah, you can't, and that's essentially what it was. They said like some of this is just because that's what you have.
Yeah.
And then another thing was, so we mentioned kind of you want to alkalinize the urine. The goal pH is 8.0 for urine pH. The serum pH is 7.5 to 7.55. And then
Right, so
Dr.
you're alkalizing the serum, right? So
Correct.
that's what you-
And then if you can't alkalinize the urine, check the potassium, which was already mentioned. Their recommendation was to keep the potassium in the high 4s range, so 4.5 to 5 is the range for your serum potassium.
Right, because it's metabolically impossible to alkalize urine in the face of hypokalemia.
Yep, exactly. So the big thing that kind of that I learned, that if I learned it in residency, I forgot it, but was the empirically treat these people with dextrose. So and then that was it. And then there talks about slides. Some of the slides from GI decontamination lecture were talking about what's old is new again in terms of using activated charcoal.
So what was their advice on, was this a New York Tox Conference?
Yeah, this was New York poisons.
So what was their advice on when to give charcoal? Like, what were their indications?
So here was, and I'm going to read right off of the final slide. Most exposures don't need GI decontamination, but for those that do, activated charcoal is good for most things. So pretty much, it's one of those where you use common sense, but at the end of the day, actually for activated charcoal, the indications, if it's a bad substance, there's no antidote, and the patient is protecting their airway, not vomiting.
Did they talk about high surface area activated charcoal?
No.
These used to be you can very low dose. And there used to be, I don't know if it's still there, but like cherry charcoal and different flavors of charcoal.
Yeah, they talked about different places have different flavors.
Right. Because I've tasted cherry charcoal because I like conferences and I tasted okay.
Yeah, that's what I brought up was one of the poison control cases that we had was a pediatric ingestion, and that was why I was like, how are you gonna get them to drink charcoal? I was like, it's got to be awful. And apparently they have multiple different flavors that are well tolerated.
Is it charcoal with sorbitol or plain charcoal?
They just did plain charcoal.
Did they mention sorbitol at all?
No, they said pretty much most places are going away from the sorbitol. They're not recommending it. It's not shown to improve any outcomes.
Yeah.
So.
Same as charcoal. All right, good. Anything else pre-hospital?
So I had just on the subject of not intubating every respiratory distress. One of the medicators brought me last week. 50-something-year-old guy had a history of alcohol abuse, but maybe he was drinking, maybe he wasn't drinking, not sure. Increasingly altered over a couple of days with a respiratory rate in the 30s, very severe respiratory. They billed it as a respiratory distress when they brought him in. So when he arrived in the ER, his tachycardia, his blood pressure was okay. Tachypnic to the 30s, very altered. He could answer a couple of questions, but wasn't really any kind of orientation at all. So the thought was that they had to put him on a neb for reasons that weren't clear to me because his lungs were clear. But anyway, turned out that he was in a severe metabolic acidosis with compensatory hyperventilation. pH was 697. And he had hepatorenal failure. His creatinine's through the roof, his transaminases were, his ammonia was over 300. So the point being is that intubating the guy, as they had considered, probably would have been detrimental,
Right.
because of the severe acidosis that he was trying to compensate
It's
for.
such a hard message to send, intubate these people early, intubate these people later. If the guy's older and, has a bad heart that you know of and can't tolerate the hypoxia, intubate those quicker. Hold off on children more. People who have, respiratory alkalosis, which you probably won't know except they're really tachypnic, intubate them. I mean, it's such a challenging message we send, and now you're back with an ambulance with a sick patient, and all I can say is, listen, if it's a rare case where you think it's a real solicited overdose, push that patient a little bit before rushing to intubate. But we're not saying don't intubate when it's indicated. I don't know, Rob, how do you send that message?
Very hard. But, you know, they're going to go fall back until what they clinically see at the time, so.
Yeah.
Yeah, and actually for this guy, held off intubating until he arrested.
Yeah.
That was the time to do it.
Until
You know.
respiratory arrest or cardiac arrest?
Very impressed.
Okay.
You know, he's still breathing 30 times a minute until he
Right.
Stop
So
it.
with a
Until he was-
right, but with a pH of 6.9 and the lactic acid, it was probably terrible.
greater than 15.
Yeah, I mean, you know, that's not a good outcome no matter what you do.
No, his mortality was 99 coming to the door.
Right, right. I mean, hepatorenal with all the other stuff is, yeah. All right, good. So we'll jump to the articles. Which one do you guys want to do first?
Let's
Well,
see.
we waited to do fixed wing for Alex to get here.
Yeah,
Yeah,
I can
we
do
did.
that.
All right.
All right.
So there's not a lot of literature, I never lecture about this, there's not a lot of literature about fixed wing.
That's what I was saying.
So they published this, and this was in AGEM, right? This is the American Journal of Emergency Medicine?
Yes. Yeah. You ready? So yes, this was an American Journal of Emergency Medicine. This just came out this year. This again, so we do a lot of our literature, especially when it comes to aeromedical EMS, comes out of Japan. They have huge. They have phenomenal records in terms of their kind of countrywide recording data, and then also they do a lot of helicopter and flight medicine. So this is another one of the articles that we're reviewing coming out of Tokyo. And essentially what they were looking at was the body temperature in patients that are being transported by air. And they're looking at the changes in body temperature and then the impact on mortality. So, what makes this article different is they were focusing on long distance transports. There had been data previously that pretty much showed that body temperature didn't really decrease significantly in short distance transports. But the reason it comes up is because in flight medicine, part of flight physiology is that as you increase altitude, you're going to have a decrease in the ambient air temperature. So the thought is when you increase at altitude, the ambient temperature is going to decrease. Does the patient's body temperature also decrease with that? And then you have to have thoughts about hypothermia, preventing that. How often do you need to check? And those are kind of the reasons this comes up. So one of the statements that was made in the paper was that it can be reasonably assumed that patients transported via aircraft over longer distances are more prone to develop hypothermia and unfavorable outcomes. So, but there were studies before showing that there was no impact in the short distance transports. In this paper, they defined long distance as greater than 100 kilometers or more than 30 minutes transport duration. This was a retrospective study. They looked at medical charts of inpatients from 2010 to 2016. This was only in patients older than 16 years old and not patients who had cardiac arrest at admission. So what they did was they pretty much collected a bunch of data, the age, sex, date of flight, the diagnoses, the duration of the flight, the body temperature at the local clinic before air transport, the body temperature at arrival at the hospital after air transport. They also looked at the severity of illness and then the rate of in-hospital death. What I found interesting was, I know there's the debate about how do you measure, what is the most accurate representation of the measurement of temperature? Was it the tympanic, the temporal thermometers, the axillary, rectal, esophageal, what's the most accurate? But here they use the eardrum thermometer or an axillary thermometer. So, I mean, from my understanding and my readings, those are not the most accurate in terms of getting a good core temperature. So that kind of raised a flag for me when I was going through this article. And then the other thing was that's what the receiving facility used to measure temperature after the flight, but the temperature measured prior to the flight at the clinic that was transferring the patient didn't necessarily use one of those measures. So you have that discrepancy there, potential confounding variable.
I think I was always told like you're about one degree Celsius off from a core temperature versus like an axillary or something like that, which kind of makes sense to me because core body temperature and peripheral temperature are going to be a little bit different.
Yeah, I mean, I know you always hear the tympanic versus the axillary. I mean, one is 2 degrees different,
Yeah.
1 degree different. It's very hard to kind of get that representation.
And if you're using different measuring, it's going to maybe you're off just by that.
Exactly. So, I mean, that was just something at least to consider when I was kind of going through, just trying to really interpret the paper. And then, so they pretty much divided the before temperature and after temperature into 3 groups. Hyperthermia, which was to greater than 38. These are all Celsius, greater than 38. Normothermia, 36 to 37.9. And then hypothermia is less than 36. So they also looked at the body temperature change before and after. So you got a temperature before, temperature after, and then looked actually that delta temperature. And the primary outcome was all-cause in-hospital mortality. So statistics, I know AJ will look into it, but quickly running down, there were a total of 1,253 patients they studied during this time period. Transport was helicopter or plane. The median flight time was 71 minutes, and the overall in-hospital mortality was 8.5%. So the mean body temperature before air transport was 36.7 and 36.3 after, and that was a statistically significant difference of minus 0.36 degrees Celsius. So essentially what it showed that there was no difference in correlation between the change in temperature and flight duration. So just because you had a longer flight didn't mean you're going to have more changes in body temperature. And then they also looked at the time of year, fall, spring, winter, summer. And there was no difference in the change in body temperature in the season of the year either. So even though there was no change with the season, they did find that winter, actually patients that were transported in winter had an increased risk of in-hospital death. Not sure what it meant. I'm not sure if it had anything to do with the flight, just happened to be the time of year. No difference in trauma versus non-trauma. And kind of quick review on the paper was essentially that there was a statistically significant difference in a decrease in the patient's body temperature during long flights, but the duration of the flight wasn't associated with the body temperature change. In-hospital death was associated with patients who were normothermic or hyperthermic before air transport, and then hypothermia after air transport, and then winter season. So while it's important to realize, yeah, there's body temperature changes, in these patients, it's more kind of what is the overall change, what does it mean? So each patient's very different. I mean, if you're having drastic changes, that's significant, but each patient's different. Just because one patient may have 0.1 degree body temperature change is not nearly as important as someone else who may have 0.3 to another patient may be much more significant. So one of the big take-homes was body temperature monitoring during transport is important for patients with not only hypothermia before air transport, but normothermia or hyperthermia before air transport. So just because you have a normothermic patient before you fly doesn't mean that they may not develop hypothermia later on, which will potentially worsen outcomes. So, and then we talked about some of the limitations in terms of different measures of how you measure it. There's no standard protocol to measure it. There was no data for the air cabin, the air temperature in the aircraft cabin. And there was no information on use of neuromuscular blockade, blood transfusions, other things that potentially lower body temperature. So essentially what they showed was that in these long distance air transports, there's a potential for a statistically significant decrease in body temperature on these long distance transports. So something definitely, if for flight medicine, you need to consider, and be sure that you keep that in your mind, be able to deal with it, and have ideas on how to prevent hypothermia.
So we do a lot of fixed wing transports with a lot of really sick kids. I wonder if some of them are getting hyperthermic.
I believe they are because I'm getting hypothermic.
Well, so
It's very
funny
cold.
because
It's a good temper. It's a good gauge.
Mike has had a lot of critically ill children lately in very long flights.
Yes,
Yeah.
and adults.
And adults.
And I mean, I've had and it's funny because I mean, and you have the different cultural and parental
Yeah.
issues that come up on these flights, and I mean, like Mike said, it's like a meat locker in there, and you're hypothermic yourself. So I mean, you've got to imagine that this pediatric patient that is already going to be hypothermic is freezing, and you try to put the covers on the patient, and the family's like, no, they're fine, they're taking them off, and it's like, the kid needs the blankets, and you're trying to fight this battle in midair over the Atlantic, and it's a little bit tougher, but I mean, I always try to keep that in mind. I know, I mean, trauma, obviously, the environmental exposure, but I mean, it doesn't necessarily need to be just in exposed patients. I mean, not having enough layering can make you hypothermic, and especially in pediatrics who have difficulty with body regulation, brain injury patients, any kind of hypothalamic injury with temperature dysregulation. I mean, it's definitely something I wonder
You're
if we don't
using,
put enough address.
with the colder ambient temperatures in the aircraft, your IV fluids are getting colder.
That's true.
Yes,
You're
they are.
infusing it
Medications
into
are
the
getting
core.
cold, so you're doing central cooling when you don't really.
You really
that's
are.
the last thing they need.
And I'm wondering if they could perform a subgroup analysis based on the type of the plane, because I've been.
That's the other thing I was
That's the
gonna
other
bring
thing.
up.
So if you're on a 777 flying commercially, no problem. They can
Yeah.
turn on the heat, doesn't affect it. If you're in a Lear 35 over the Atlantic, they turn on the
I
heater,
think
all of a
it's
sudden
go-
you hear the engine get cut back 50%. You're like, oh, well, okay, it's going to take us another 3 hours to get there. Do we have a medication? You know, you can feel the impact of the heater on the engine. So. You know, I'm sure it really depends. My last flight, it was just like that scene from Apollo 13 with Tom Hanks like throwing the little frozen hot dog around and, you know, trying to eat it, but they couldn't because it was frozen. So, you know, you make sacrifices of hypothermia for getting there on time. I guess that's reasonable.
Also, a lot of these smaller aircraft, the patient's right against the wall or they're right against the window.
Yeah.
So, because there's just
That's,
literally
yeah, that's
nowhere
the
else for
point.
them
The
to
windows
be.
are cold. So always put the shades down because the shades actually provide some layer.
Yeah, and
Unless
then,
the sun's out.
and
Unless
then
the
also
sun's out,
padding,
yeah.
you know, to kind of insulate them from the cold.
So AJ, what do you think statistically?
This,
First thing I always usually look at is the box plot on page 3. You'll see that the before and after, there's not a lot of outliers concerning body temperature, and especially so if you were to zoom out from 0 to 39 instead of 33 to 39. So what I'm trying to get at is that if you scaled back the sample size to about 100, there would not be a significant difference. And so that's probably something to consider, the large sample size, which found the effect. Maybe some hints at it being overpowered in that regard for the box plot figuring. And there's not a lot of extreme outliers with this, which is really good.
So then I saw they use mean sometimes and median. So tell me your rules again for when to pick mean, when to pick median.
Yeah, so as I said last week, mean, median, and mode, when you have a normal distribution, will be the same value, always. And when you have skewed values, the mean no longer works. It will be actually below the median on average. And so the median is the best approximation of the average at that point when you have skewed data sets. And the reason we're flipping in between with this one is because we don't really have a lot of outliers or a really skewed data set, as you can see with the box plot.
Okay.
I got really excited.
And let's see, on table 2, something I thought I'd mention is we have multivariate logistic regression. Multivariate just meaning they put all the independent variables in the model at the same time and tested them all together. And winter was most significant. So this was in hospital mortality and not body temperature, but interesting that winter is predicting the most in hospital mortality above the other seasons, which are non-significant, which may have something to do there with just seasonal variety.
So then tell me for the last time, and then I'll probably commit it to memory, is by eyeballing that confidence interval, how do you know if it's too wide or not? For let's say winter. For like winter?
For winter, for so 1.08 to 4.27?
Yes.
Well, statistically, anything over one is significant. It's always going to be that way. But depending on the sample size is what predicts how large it's going to vary. And it's a direct correlation to the sample size. For instance, if you took the sample size from 1253, and in probably the winter category, there is about 400 people, and if you drop that down to 100, this would probably not be significant anymore. It'd probably go into the left side and the right side of one. So depending on, it's really due to the clinical significance. You really don't want it to be more than twice your estimate. So this is very borderline, as you can see with the effect size of 2.15 for the odds ratio. It's very borderline with a confidence interval, but it's still significant.
Okay, and just for the new people who are tuning in, just give me the English version of what that 2.35 odds ratio means.
So there's like odds ratio and there's relative risk. Odds ratio is just your increased odds of having an hospital mortality with the exposure of winter. That's like the exact definition. So you have to think of it as an exposure to winter, increasing the odds of it, your in-hospital mortality.
So exposure to winter increases in-hospital mortality by 2.35 as a multiple?
As a multiplier, yes.
2.35 fold.
2.35 fold. All right.
Where's 2.35 at?
Or 2.15, I think, is
Is it
2.15. Yeah,
Can't see.
2.15.
Yeah, I meant 2.15.
Okay, yeah. And if it was relative risk, it would be increased the risk. Relative risk, or RR, and odds ratio are calculated a little differently. And odds ratio is usually always calculated with logistic regression in most of these retrospective studies.
Okay. And then, all right. Other questions on stats? No?
I don't have any.
Okay. Want to go to the next article? What are we doing next?
Sure. Let me switch back over to us. What's next? Do you want to talk about the isopropanol aromatherapy?
Yeah. So normally, I only try and include EMS stuff, although I kept reading this article and I kept thinking about a medic or EMT in the back of an ambulance with isopropyl alcohol in front of somebody's nose, and I kept thinking, how easy is this? And then I kept thinking that if this is an EMT and it's a drug, do I need somebody's permission to do this? And then I kept thinking, on a BLS ambulance, are there isopropyl alcohol pads on BLS ambulances? Are there?
Yeah.
Is that a national
Yeah.
requirement?
Yeah.
So, I don't know, I just thought this was kind of cool. Although I know some people have been doing this for decades, I'm not sure I've ever read a study about it.
Yeah, so I'll preface this story with, or preface this article with a little story. There have been multiple articles testing this concept. We reviewed one of them in our residency journal club, and shortly thereafter I got to the norovirus that was going around that year. So I was very ill, and it hit me while I was on shift in pediatrics. So I didn't have any Zofran with me at the time, or Odansetron, and at the time, I was able to find some alcohol pads, so I'm walking around the pediatric ER going, in between patients, kind of like, and I'm pretty sure one of the parents reported me to the attending pediatric on call because they thought I was sniffing some kind of inhalant to get me high. But it was, I didn't think I looked like I was really enjoying it that much. I was kind of sneaking in the corner and sniffing it. It actually worked really well for me. So ever since then, I've been handing them out to family members who feel nauseated on like an airplane or something. But
Really?
Yeah.
And so you're just opening up the package and just putting it right, and it works right away?
Just sniffing it. It works. It worked immediately for me. Maybe it's because I just read the article and I had high expectations. But now, whenever I'm nauseated, I give it a try. I'm not gonna lie, it works for me.
How long does it go away for, the nauseousness?
Every sniff probably lasted me about 10 to 15 minutes.
Really?
So
It's non-invasive, it's
repeated
widely
sniffing.
available, and it's cheap.
yeah.
Why not?
So
If you use too much, you have to remember your toxic alcohol ingestion.
yeah, but even still, you drink a half a liter of isopropanol. You make some acetone and you metabolize it. So whatever.
Right.
Yeah, so this was an interesting story, and I can vouch for its efficacy. So essentially, you know, their background, they talked about a few animal models that demonstrated its concept and in safety, but then they talked about a number of single randomized controlled trials that demonstrated the superior nausea relief, as I just described, with inhaled isopropanol. And they were testing that against saline placebo. So the majority of the existing randomized trials, though, they didn't really look beyond 10 minutes. And that's actually what I demonstrated with myself. It doesn't really last longer than 10, 15 minutes. But these trials didn't really measure it beyond 10 minutes. So major goal, first off, of this trial was to say how long, in fact, will this last. The importance, as we can imagine, nausea, vomiting, probably one of the major chief complaints presenting to the emergency department, with 4.8 million that they quoted. I believe that was CDC data. So, you know, the goals, as I mentioned briefly, of this study was to compare nasally inhaled isopropyl alcohol versus oral ondansetron for treating nausea among ED patients. So this was another single-center, placebo-controlled, blinded, randomized, all these good words that we want to hear, except multi-center obviously would be a little bit better, right? We want a diverse population. And they were randomized into one of three groups. So they had the inhaled isopropyl alcohol group and 4 milligram ondansetron group. And they had inhaled isopropanol plus oral placebo. And then the third group was inhaled saline solution placebo plus 4 milligrams of ondansetron. So you're probably wondering, so they did have a dual treatment or a non-placebo arm because there's no true negative. The reason that they didn't have a true negative placebo group is because they wanted to blind subjects to inhaled intervention. By blinding them, that may be ineffective because essentially the patients may know they're not getting any treatment at all. You know, they wanted to have at least one arm and compare dual treatments and then individually plus placebo. So. Their study setting, urban tertiary academic hospital, so similar to where a lot of us work, 84,000 visits a year. It's certainly comparable. And this is really convenient sampling from what I could tell. So the nurses, the nursing staff, and the investigators would enroll based on the hours that they were there during the day. So basically, you know, during the day. So unfortunately, patients who were coming in with nausea and vomiting at night probably weren't included. Or if any of the investigators were working night shifts, maybe they did get included. Exclusion criteria, if they had a known allergy to isopropyl alcohol, that makes sense. Inability to inhale through the nares. I guess that makes sense, right? If you can't breathe through your nose, yeah, you can't sniff the stuff, so we got to exclude you. Thought this one, a known history of QT segment prolongation. I guess there was some concern that ondansetron would have an effect on the QT syndrome, QTC. We can talk about that a little bit more later, as I'm sure we've touched on it in Journal Club a few times. And then clinical suspicion for serotonin syndrome was also an exclusion. That's interesting. So you can actually look at the figure 1 that kind of shows how they were approached, and then they excluded 61 patients from 208 down to a randomized group of 122. And then for each of the arms, there was about 40 people per group. So that's figure 1 that really sums that up. So you're wondering, well, what was the placebo? That's what I was wondering. So the placebo for the ondansetron, so, you know, the groups that were getting ondansetron, it was 4 milligrams per 5 ml. So that was an oral solution they were just squirting into the back of these patients, so 5 mLs of fluid. And then the placebo for that was sterile water mixed with Orasweet. I guess Orasweet is just sucrose or sugar or something like that.
Similar to the binder.
Ultimately,
so.
maybe they tested to make sure it tastes similar to ondansetron.
Yeah.
And then isopropyl alcohol, but the placebo for isopropyl alcohol was a saline solution pad. And each of the patients would hold it 1 to 2 centimeters from the nares and sniff. And they measured the effect of nausea on a percentage scale, basically 0 to 100%, 100% being the worst nausea you've ever had in your life, and the 0% being absolutely no nausea at all. And that was their primary outcome that they were measuring, the reduction of that number. Their secondary outcomes, they were looking at a few other things like a reduction of pain and a few other secondary outcomes. So what do you think? Did it work? So if you start to look at some of the results down in, so first of all, table 1, compare your baseline characteristics between all the groups. There were some differences. You know, the age mean in the arms wasn't exactly on. It was 34, and then 29.25. So they were similar across the board. But the middle arm inhaled isopropyl alcohol plus placebo was a little higher. The sexes were a little variable. Otherwise, weight and the rest seemed to be pretty comparable across the board. So you can look at table 1 for that. And they also went into kind of presumed causes of nausea. So table 2 kind of points that out, with infectious gastroenteritis being the number 1 cause that they thought was at the top of the list. Food poisoning was below that, and a number of others below those. So you kind of get into the meat of the results by looking at figure 2. And they kind of posted each of the arms, A, B, and C. And I think the most important is the pre and post bars that they have at the end of those downtrending tables, because that really shows the before and the after for each group as a whole, averaged together. Whereas each individual patient average for each group is kind of trended down. That graph was a little confusing to me. So I thought it was the pre and post bars at the end of that downtrending slope was really what made me kind of understand what they were finding. So figure 3, the mean nausea VAS scores, visual analog scale scores, was kind of demonstrated based in figure 3. It gives a different graphical representation, which I'm sure AJ will comment on once we get to him. So if you look at each of the arms, the worst performer in decreasing nausea was our third arm, which was inhaled placebo plus oral ondansetron. So just Zofran alone was the worst performer. And then comparable, the other two, isopropanol plus Zofran or isopropanol plus placebo, actually performed, both of those performed comparably similar and better than the third. And that was really interesting. So, the discussion, they brought up a number of valid points. They thought it should be introduced as a supplement to our usual care in the emergency department, to use it alone as a single treatment entity, like I was walking through the pediatric emergency department that one day. Maybe it's not a viable option. I think it's worth testing, though, as an individual therapy as compared to a standard that we're using, just to see how it measures up. I think it would potentially, alone, without ondansetron, would perform, as we demonstrated in that second treatment arm. So it, especially with all of our dwindling supplies of Zofran in the world and Reglan, it's a viable option as a single treatment, I think, and I think we should definitely be trying it.
So do all alcohol pads isopropyl alcohol or something else?
I think some are ethanol, aren't they?
No, I don't think they make pads with ethanol.
No, I don't think so.
Because ethanol has ethanol's in the squirty Purell things.
Yeah,
right?
I've never seen anything but isopropanol.
With ethanol.
Pads.
I think they
You haven't
have
seen anything with
different.
what?
I haven't seen anything but the isopropanol and pads.
Or ethanol.
You mean
Yeah,
ethanol?
ethanol.
No, I've never seen an ethanol pad.
Right, but you just said isopropyl.
That's always it.
That's
Yeah.
always.
Yeah, that's it.
So, Bob, can I have BLS do this?
Oh, right now we can have ALS do it.
Right, well, forget ALS. So ALS is easy, but isopropyl alcohol is theoretically a drug. Can I have BLS give a drug to a patient?
You're allowed to carry it.
If they're allowed to carry it.
They're allowed to carry it, and we don't monitor the route by which they give it.
No, they're not administering it.
So I have to say they're allowed to carry oxygen, and that's a drug that's used readily every day. You know.
These are all. This is over the counter, right? You know, this is you can buy this over the counter.
Sure.
Yes, you can.
I imagine it would be an off-label indication, off-label use of the isopropyl alcohol.
I see
So that might be problematic.
$1.35 for a box of 50.
$1.35.
Cheaper than Zofran.
$2 for a box of
Probably
100.
just put the Zofran ODT on the ambulances, right?
Yep.
Because we're all but running out of IV Zofran.
How do you think they blinded the inhaled arm? Inhaled saline doesn't
Yeah.
smell like
Have the
inhaled
same-
isopropyl
So
alcohol.
in reality, the patients didn't know what they were going to be sniffing, so I could see how they could be blinded. I guess they were instructed by the investigators to not react to what they were what they were smelling. Additionally, the investigators, if they had to assist the patients with opening the pad, they had to hold it at an arm length away, so they were unable to smell it. So
You gotta try
questionable
double
whether or
blind.
not that's.
Well, they probably didn't know if the isopropyl was the
The control or
The
the
control or
the treatment, yeah.
So Bob, should we send in an email out to all our medics to say? I mean, we don't have IV Zofran, right? We have Zofran ODT now. You can nebulize Zofran. Most people don't know that, but you can do that. But you still need the liquid solution.
I think it's worth a shot.
Should we just send an email to everybody to say something? I mean, we have plenty of Zofran ODT now, right? That's
Yeah.
coming in, and there's plenty of stuff. In fact, I remember when we ran out in the hospital of IV Zofran, so we were giving Zofran ODT to people who were actively throwing up. And you always say you shouldn't give anything by mouth if you're throwing up. We would do it, and they would stop throwing up, right?
So what's the onset of the oral Zofran that they were using?
Was it ODT or was it just?
No, they were using a liquid formulation, 4
Ah.
milligrams in 5 milliliters, and it was liquid. And their placebo was also liquid.
Let me see that.
So what's
Is that just the
onset?
IV version? They just gave
20
it
minutes.
PO?
But the problem, I don't know the answer to that, but the question is if some of this got under their tongue, they bypassed first pass metabolism and had it directly absorbed. So it's a tough question to know what the answer is or how to make sense of it. But for the Zofran ODT, that's very, very quick.
Right. No, I was just wondering, because they were talking about, 30-minute time frame.
Right, because that's oral and swallowing it and stuff. Yeah, so.
And why 4
should we
milligrams
send an
and not
email out
8?
to tell everybody just consider this?
You could, yeah.
Yeah. Yeah, the medical control physicians, I guess, yeah. Monitor transport, PRN for idazofran or
Or alcohol
for
pad?
isopropanol pads.
One alcohol
Twice.
prep every 15 minutes.
Clean their nose with alcohol prep pad.
Yes.
I don't know if you want to see the stuff that comes off, though. I mean,
Right. So you shouldn't use the same alcohol prep that you're storing the IV with, for sure.
Well, after you start the IV.
Yeah.
You gotta conserve.
Pat, you ever do this in the emergency departments?
No.
No. But I tell you, one of the physicians just told me that when she had her baby in LND, they told her to do this a couple of times, right? So they said, yeah, this isn't, and I think she had her first kid a couple of years ago, so she'll.
I mean, it's been in the literature. The earliest thing I see is like Journal of Plastic Surgery from 2004. We reviewed this actually in 2016, 2015, when they published. This is the same group published their original article where it says, "Hey, this works."
All right, so
Did they say how much was in the pad?
I think it's at like 70%.
70% isopropyl alcohol.
Yeah.
I believe.
So does that mean it's 700 milligrams per ml? And then how much you're actually absorbing?
It's just like a nebulizer, a little bit for you, a little bit for the air.
Yeah. All right, so let's do this for everybody who's nauseous or vomiting. I guess there's no downside. Except you make little acetone, right? Mike?
Yeah.
I
A
gotta
little
figure-
acetone.
I was gonna say, I gotta figure out an intervention on it, though.
So how do you want this documented?
Yeah. I have to figure out an intervention, how to,
Is it considered that you're administering a drug?
I don't know.
yeah, but that's the only way we'd be able to.
Inhalation. It's inhalation, just like a nebulizer.
What are they documenting if an ALS unit gives like 2 liters nasal cannula? They're just
Oxygen.
documenting, right? They're just documenting oxygen.
Oxygen is an intervention.
And then they do documenting inhalation with the oxygen.
Can't they?
Yeah, it's
use
one of the
inhalers?
qualifiers.
That's one of the qualifiers. What?
Can't they have the patient use their own inhaler? How do they document that?
Whatever the medication is.
But this is not the patient's alcohol prep, it's our alcohol prep.
One of the qualifiers here was also that these were patients that were presenting with acute nausea that didn't otherwise need immediate intravenous access. So I feel like for some of the medic units, they may start thinking, oh, well, this guy's having an MI, we're doing all these other things, but he's also nauseous, let me stick some alcohol underneath his nose. I don't know if that necessarily is going to obtain the same,
maybe.
the same outcome as these.
Maybe. I'm going to start doing this.
So Pat, what's your ER going to say when the medics come in?
One pad for each nostril, or is it just one?
They're going to do an IR report. The medic is having patients sniff out isopropyl alcohol.
Can you imagine what our waiting rooms are going to look like?
Walk in the waiting room, in the corner sniffing.
My ER does this.
They're all
familiar with it. We do this a
You
lot.
do all the time?
Yeah.
And I mean, what's the general thought about how well it works?
I don't
I
know.
mean, what's
I
your
mean,
experience how well it works?
So I've only done it with people who have used Reglan and Zofran, and they're still nauseous. And I've given it to them, they're still nauseous. So I don't know.
So you're it's a little bit selection.
Have you
about
ever done a first line?
I haven't. I don't think. For myself, I have. But that's it. I mean, that's.
I mean, by the time you get started an IV and give them IV meds, the alcohol prep takes 2 seconds.
Yeah.
I know.
This could be something in
Or
triage.
sniff this
Just give
while
them
I'm
the
sitting,
alcohol
getting your
swab.
IV
Yeah, it could
ready.
be
You know?
triage protocol.
Yeah.
When you check in, here's your insurance card, here's your alcohol.
I don't remember what any of these.
How about with every MSS patient, we give them an alcohol pad?
Right.
Yeah.
Yeah, that's not bad. Were there any? What was the age cutoff in this study? How young did they go?
16.
So is
16?
there any reason you can't do it in peds? I mean, kids get gastros all the time.
How do you think parents would be comfortable with that? Here, sniff this kid.
It's also something that they might
They
eat.
probably already did it because they were rubbing the kid down with alcohol at home.
It's true. That's valid.
Maybe that's the real reason why it
There's
works.
No alcohol baths. We have lots of studies to say that's the wrong thing to do.
Terrible idea.
And Mike, you brought this up briefly. Do you want to talk about the QT prolongation with Zofran?
Yeah, so it's apparently a thing. If you go to prolongqtdrugs.com, I believe is the website, every single drug ever invented on the face of the planet can theoretically prolong your QTC. But I believe there was a Cochrane review, a meta-analysis, looking at QTC prolongation. I don't know if...
Yeah, and I mean, I'm a believer in 8 of Zofran for the average adult because it's really 0.15 if you calculate out 0.15 per kilo. So we underdose. It's always silly to me how we will give an adult 4 milligrams, but a kid might get a little bit more, depending on how much they weigh. But
Yeah. And you think about the cancer patients who are getting 16 plus
still,
32 milligrams at
all
a
the
time,
time, around
and you
the
sit
clock.
there and you stare. That was the meta-analysis. You stare at their QTC. There's absolutely no
And
change
we know
at
when
all.
somebody
I mean,
has cancer and they're on chemotherapy, you don't just give them a one-time dose to help the nauseousness. The best way to handle nauseousness on chemo is around the clock. Whether they're nauseous or not, give it around the clock and that will take it away.
But I remember 4 or 5 years ago, we got a notification from our legal department at our practice about Zofran and QTC and get an EKG before you give Zofran, which I think is silly, but that's, actually had guidance from our legal department about that.
I still get blocked by the pharmacy at some hospitals for ordering more than 4 milligrams IV at a time.
Yeah, absolutely.
Right. I've had somebody say to me once from psych, you can't give Haldol before you get a 12-lead EKG. And because of QT prolongation, you're thinking the guy is fighting with everybody. You want me to get a 12-lead EKG before I give Haldol? Now, thank goodness we don't really give Haldol that much anymore.
Well, you're going to have to now. There's no more.
I use it as an antiemetic first line, by the way, now.
What?
Antiemetic Haldol. It's great. For I'm serious, for the retching vomiters. Like,
yes, but you want to elaborate on that, so you want to talk about that?
Yes, I mean, and we're finding now shortages of our first line antiemetics, ondansetron and metoclopramide. We're looking for compazines coming back. and haloperidol is a wonderful antiemetic. I mean, it's droperidol, right? And it's
Oh, for the good old days.
I was using it as a second or third line in patients who have like cyclic vomiting syndrome or cannabis hyperemesis, or the real retchers who come in and you just cannot get them to stop. So 2 IM.
So cannabis hyperemesis, oh my goodness, it didn't
exist up until
before, and now
right.
everybody who comes in because they smoke some weed is now vomiting with cannabis hyperemesis diagnosis.
Right. So it's in
what were we wrong
selection
before, or are we wrong
bias.
now? Right. And I thought you smoked cannabis because you're nauseous. And now people, everybody starts cannabis hyperemesis, and I'm like, I don't know, maybe the guy's just throwing up and he happens to smoke some weed, and maybe we don't give it a fancy name. Maybe it'll stop, and and he can still go home.
Yeah. When I think cannabis hyperemesis, I'm thinking more of a cyclic vomiting presentation where these people, they have I've seen it a number of times where they come in, they say, I have to take a hot shower in order to get it to stop.
Okay.
The only thing, those are the things that I'm considering it as an actual diagnosis where I consider using haloperidol.
But what we're talking about is a pretty decent antiemetic. I don't know the numbers, but it is pretty decent. It's been talked about for years in the science. And droperidol is a drug that got an unfair black box warning that a lot of people stopped using because of this unfair QTC prolongation, an unfair black box warning. But yet in other parts of the country and the world, they give droperidol like it's water, and they've ignored the black box warning. Maybe because we have too many lawyers on the East Coast. But have you guys given droperidol recently?
I haven't been able to find it.
Yeah, I don't think it's on formulary in most hospitals if you have
through
Haldol.
South Carolina, and he goes in all his rotations, they're giving droperidol first line.
Yeah,
Wow.
I mean,
There's more and more places using it now.
we had it where I did residency. We had it for 2 days. The attendings who had used it other places in those 2 days used all the short supply that we had in 2 days because they loved it. I mean, we used it. We used it for everything.
Because everybody who used to use it said like this was an amazing drug. It worked really, really well.
That's why I'm fortunate to understand one of the articles that I'm going to present at the conference about excited delirium, agitation, and stuff. It was a 2016 article, and they used droperidol nonstop in this study. I was like, man, I want to go where they are because they clearly have enough to do this huge study with droperidol.
Right.
So comparing it to ketamine and benzos and stuff like that, but I mean, I've heard magic about that.
Right. And if you look at the papers or you ever go to a presentation on this, almost all of the patients who had droperidol with QT prolongation, you couldn't prove they got worse by the QT prolongation. It was terrible. It wasn't even that many patients, but that's what we do. We get rid of a good drug.
Yeah.
All right, AJ, anything stats-wise?
I don't really have major criticisms. They did everything I would have suggested with Bonferroni, and they defined a clinically significant bound by which they were detecting. They finally powered a study because we haven't been going over a lot of studies that have been using power to find clinical significance. Overall, the study definitely is proving aromatherapy is working better post. Unless you have any questions, I don't really have much more to add than that.
Mike, what do you have? All right, so what table is this?
Oh, figure, is that figure 2?
Mike, what were your questions?
I just thought it was an interesting way to represent the data. I basically only needed the pre and the post mean bars at the end. I'm not sure the subject's representation from 0. Yeah, I don't really see any point to that, but yeah.
The points, the box plots?
Yeah.
Well, the box plots show you how far they're going to range. Oh, and it also shows you the mean value
For each individual. Yeah, to the left
To
portion.
the left of the box plots, basically the little circles with the lines, vertical lines.
Subjects, each individual subject on the left part.
To the left of those boxes.
The question's about the lines for the dots?
Yes.
Yes.
Oh, okay. So I'm having trouble hearing with so many voices.
Sorry.
I would assume they're the confidence interval for each line, and that you have multiple line dots on top of each other creating confidence intervals. Because on my screen, they're changing thickness between lines.
Yeah.
All right. Okay, that sounds good. What's the next article?
I can do the penetrating trauma.
All right, so why don't we take 10 minutes on the penetrating trauma, and then we'll just finish up with the toxidromes.
Okay.
So I like this.
I like
A
this.
bunch of people are talking about this paper.
So this is coming from a Journal of Trauma and Acute Care Surgery. It says this is using the National Trauma Data Bank from 2007 to 2010. Or I'm sorry, 2007 to 2014, and they break it up into two different groups, early and late. But what they're doing is they're analyzing the trends in pre-hospital mortality from penetrating trauma. So penetrating trauma is going to be defined as stabbing, gunshot wounds, and stab wounds. And again, this is for the American College of Surgeons has a national trauma data bank. So patients that report to trauma centers get coded as a traumatic injury, stab wound, gunshot, and then get put into this data bank. So from 2007 to 2010, that was considered the early period of this most recent decade that's gone by, and the late period of the decade was 2011 to 2014. So essentially what they were looking at were differences in body locations of trauma. So where were the patients stabbed and shot? What was the pre-hospital mortality? And then what was the in-hospital mortality? So kind of going through is pretty neat to see what so the National Academies of Medicine pretty much says that we have to consider every phase of care, including pre-hospital care, to really understand how we're benefiting these patients. So the hypothesis was that there would be an increase in the incidence of penetrating trauma, as well as an increase in pre-hospital and in-hospital mortality. However, that's not what they found. They actually found that there was an increase in pre-hospital mortality with a decrease in in-hospital mortality. So this was patients at least 15 years old, so not every study includes patients this young. And they presented to hospitals that recorded dead on arrival statistics. So not every hospital will do that, but that's kind of what they were looking at. So pretty much the primary outcome was pre-hospital mortality. So essentially that was the hospitals reported the patient was dead on arrival or arrived with no signs of life. That's kind of what they looked at, and that was no organized EKG activity, essentially your obvious signs of life. Secondary outcome in hospital mortality, which was death either in the emergency department or in the hospital during their hospitalization. And I'll let AJ talk more about the statistics, but I mean, there were a significant amount of patients. There were 437,398 patients. 752 hospitals represented, and it was 50-50 gunshots and stab wounds. So I thought that was pretty neat that they were able to kind of get a 50-50 on the type of penetrating trauma. The majority of patients only got stabbed in one body part, so good for them. They were able to escape. And then it says that the overall unadjusted mortality rate remains similar between the two periods for gunshot wounds and stab wounds. So the majority, and among the patients who died, the 36,000 patients who died from penetrating trauma, most of them died from gunshot wounds. That was the penetrating trauma that was most lethal. And then again, there were unadjusted differences in pre-hospital mortality and in-hospital mortality. So the risk-adjusted pre-hospital mortality rates increased, but the risk-adjusted in-hospital mortality rates decreased. So the patients who experienced penetrating trauma in the late period, so that was 2011 to 2014, they had significantly higher odds of pre-hospital mortality, and that's both gunshots and stab wounds. So in the more recent times, again 2011 to 2014, pre-hospital mortality was significantly higher. But individuals arriving to the hospital alive had significantly lower adjusted odds of in-hospital mortality. So getting the patients to the hospital was very important. If they made it to the hospital alive, they had less mortality. The scary thing is there's an upward trend of pre-hospital mortality rates for both gunshot wounds and stab wounds. Also in the late period, we are also seeing more injuries to the face. So more penetrating trauma to the face, stab wounds, and gunshot wounds to the face. So what I was talking about was after adjusting, and AJ will talk probably about the statistics, but the odds of pre-hospital mortality increased by up to 4 times for gunshot wounds and up to 8 times for stab wounds. So among individuals who experienced one of those types of penetrating trauma, there's significant decrease in in-hospital mortality as long as they made it there. And then one of the statements was, while the overall mortality for penetrating trauma has remained relatively flat, the location appears to have changed. So it used to be that more patients would die in the hospital, now more patients are dying pre-hospitally. One of the potential reasons for this is more aggressive violence, more high caliber ammunition, especially with gunshot wounds. And I'll make this just because say this just because I'm going to be going to Baltimore, but recent studies found that pre-hospital mortality from penetrating trauma nearly doubled from 1.7% to 3.1% within a span of 5 years in Baltimore, even with the implementation of a disciplinary youth violence prevention initiative. So, I mean, and then it also goes on to talk about the financial cost, the financial burden for pretty much each firearm-related injury has a cost exceeding $100,000 in terms of medical
So the
care.
financial burden per person, could it go down? Because if you have more people dying pre-hospitally, you have less kids who wind up in the hospital in the ICU for a month with $5 million bills.
Yep.
Am I wrong?
No, that's exactly what that's actually one of the points I was going to bring up was that, I was going to bring up that point in terms of you'd think that there would be a decreased burden because you're not going to have all the hospital bills.
Right.
But then on the other end, from an EMS standpoint,
Because the cost to be in an ICU depends upon whose people you believe, $50,000 to $100,000 a day, right? Especially for an active person who's getting procedures done, sometimes more. So, and the cost to these patients is that they get trach, they get peg tube, they get those injuries take a long time to figure out, and a lot of stuff is being done. So they have huge bills, and so in Baltimore, mortality is going from 1.7 to 3.4% for penetrating trauma pre-hospitally, because they're aiming more to kill the bad guys?
yes,
Is that why?
so it's saying the intensity of the traumatic incidents has increased, and then also for the gunshots, you're seeing a much higher high velocity, high caliber weapons. So
that's why.
The initial
so it's a different weapon?
Yeah, the different weapons.
Because 10 years ago, the bad guys had to be aiming to kill no matter what, right? That has to be the same now. They have to be aiming to kill. Unless before they were aiming just to maim and not to kill.
Better weapons.
I think you were seeing.
Better
I think
weapons.
you were
Better
seeing.
weapons.
Yeah, the ammunition. I think you were seeing different caliber weapons back then. You're seeing a lot more high-powered assault rifles, semi-automatic weapons that have much higher, pretty much power.
Because I'm under the impression that nationwide, the number of in-hospital penetrating traumas is decreasing.
There's also some assault weapons bans that have expired in that period of time.
During the time of this study?
I think so.
But do
I think
criminals
some-
follow weapons bans?
There's more on the street.
That's true.
And even specifically says like Baltimore is experiencing its highest rate of gun violence, and it's essentially because there are one of the popularized catchphrases "shoot to kill," and that's what is pretty much being told in all the gangs and the drug trade and everything is.
And this
Shoot
doesn't
to kill.
include Chicago in the last 2 or 3 years, which is
No, exactly. Yeah,
crazy.
this is
Right.
up to 2000.
So maybe it's
14.
pockets in the United States are increasing with penetrating trauma, but overall numbers are decreasing. Although I get all the state, we get a lot of the state police information, and we see huge numbers of gunshot wounds every day.
I know the New York Times recently, I think in 2014, released this article that was showing a graph, increasing or decreasing murders and gun violence overall,
Right.
but certain populations like they had Newark, they had Baltimore, they were on the rise.
That sounds exactly right.
Yeah.
That's exactly what I'm reading too from like MMWR and stuff.
Yeah.
But they're not talking about absolute numbers, they're just talking about lethality of the ones out there. So even though the
Right.
numbers are up or down, overall doesn't really matter, it's just the lethality of the...
Right.
Alex, was this just patients to trauma centers?
Yes. This
So-
was American College of Surgeons Trauma Registry, level 1 trauma centers.
All right,
Yeah,
so
so
a
they have
lot
to
of
be.
our...
Level 1 and level 2.
A lot of our penetrating traumas won't go to, a mortality in the field won't go to the trauma center.
Right. So you're saying if you're like below the knee or below the elbow, you may go to a community hospital.
Well, even if we got somebody in the field, we had one within the past 2 weeks that it was a gunshot wound to the head that was TRE to the local hospital. That would never show in this statistic.
Right.
Right.
And
So you're
we
saying that
we have that.
some GSWs to the head will take to a community hospital with like TRE with no signs of life.
Right.
But other GSWs to the head who do have potential for survival, we take to trauma centers.
In our coverage area, the only gunshot wounds to the head that are codes that go to a trauma center are within the catchment area of the trauma center.
Right.
Everybody else is going to go to the local hospital.
Yeah, but a GSW to the head who has chance of survival, it probably should go to a trauma center depending upon your geographic area, right? Because
Right.
if you're, in some states, if you have one trauma center for the state, you're gonna have a lot of local hospitals, we do this weird, because in our state, we only have level 1s, level 2s, and level 3s, and level 4s. Many other states around the country, every hospital, I was just in a state where every hospital is a trauma center. And the community hospital, which has no trauma, is a level 4 trauma center.
Yes.
Right, so if you have one trauma center far away, you're bringing everybody to the community hospital and letting them figure out what's gonna happen. And if you have a GSW to the head, that's, transcranial with no chance of survival, there's no point in transferring that, right? But if they may be on a vent and may not survive for 2 weeks, then maybe transfer the patient because maybe they might survive, and they'll need interventions that only the tertiary care center can do. So what was your take-home message here?
I think we're seeing, the take-home message, I think, was that we're seeing a pretty disturbing trend of increasing violence, and we're seeing the increased pre-hospital mortality. But I think what I've taken away from this is we still need to go with if some people have, unless they're dead on arrival at scene, get these patients with penetrating trauma to the hospital as quickly as possible, because once you get them there, they have decreased mortality. So grab and go technique, which we know, which we already do in trauma, I think is more of a grab and go, whatever you need to do on your way. And then it wasn't addressed in this article, it was mentioned somewhat because it mentioned antifibrinolytics, but TXA. But essentially what they were saying is that I think once we get patients to the hospital, we have more tools, we have antifibrinolytics, we have other things that we can do.
We
to
show
get
the
these
TXA pre-hospital.
Yeah, exactly. And so it's like, we can now move some of this stuff
Don't give
pre-hospital.
IV fluids if you're stalled at least 90, particularly in penetrating trauma. Give a gram of TXA right off the bat for if they're symptomatic, and you can make a healthy argument if they're shot in the box, which is the chest or abdomen, just give TXA with normal vital signs. Right? People around the world can do that. And no questions asked. And then if you don't hear good breath sounds, or if you think you don't, just decompress the chest. Right? And if the guy's in cardiac arrest, decompress bilaterally, no questions asked. Right?
And then one of the other things that I found interesting was a study showing that the National Trauma Data Bank found that private vehicle transportation had lower odds of risk-adjusted in-hospital mortality relative to ground EMS.
Yeah, that's all the Philadelphia data.
Yeah, in urban communities.
We reviewed that
It's a
article,
long
yeah.
story, but it's a long story. We've talked about these articles over and over again. I mean, if Philadelphia is known for penetrating trauma being thrown into the back of police cars and driven fast to hospitals, right? That's nothing new. So if that's how your system operates better, I'm not surprised that they have better outcomes with less medical care, right? That wouldn't work well in other places whatsoever,
Oh, yeah.
right?
Yeah.
But in that system, I'm not surprised, right?
Yeah, that's what I mean. That's what it's at urban communities, but I mean, that is not going to work well everywhere. I just found it funny. All that pops in my mind is like
This is why in
an
some
Uber driving a gunshot.
this is why in some places trauma is all BLS, right? That works well in some places. It wouldn't work well in other places.
And then for us for pre-hospital, talking about they couldn't, with their database didn't look at pre-hospital times and pre-hospital interventions. So it says there's a potential area of improvement for future data collection. And I think that's true. I mean, a lot of times, and we've talked about it in terms of the patient handoff and things like that, they may not know what you did pre-hospitally because there's so, especially on the trauma. I mean, if that patient's unstable, they get to the trauma bay, no one's listening to what you did pre-hospitally unless they can see it, because you put a three-sided chest seal on or something. They don't know or care what you did pre-hospitally. So I agree. I think that's somewhere we can improve from an EMS community standpoint.
Yeah. We want just 5 minutes on the Toxtrom article, maybe talk about it a little bit next time too. We'll end with that and start with that.
Sure.
So AJ, comments with this?
Just a few critiques. Like on table 1 for the demographics, or page 23, you'll see like all the p-values are significant. From a statistical perspective, of course they're going to be. You had 437,000 people in your study. If you drop that down to 150, nearly none of these are significant. So the p-value here is a little ambiguous, doesn't need to be presented. Let's see, table 2. One thing I thought to mention was, so we're having lower risk with our adjusted odds ratio with in-hospital mortality, which definitely does suggest that care is getting better per year since then, although gun violence is increasing, which may make the difficulty of the 2011-2014 period with an increase, what is it? Yeah, adjusted odds ratio. Okay. And I would like to point out that the large confidence intervals you're seeing in the table just means low prevalence within the study. So you can nearly throw them all out and not take them into consideration when you're having these large confidence intervals like from 12 to 37.
Interesting. So can you just put into perspective studies that we review that look at unadjusted and adjusted mortality? Just tell me when you decide to do that. We haven't talked about this, adjusted, unadjusted, what it really means. We always talk about articles to say the unadjusted wasn't statistically significant, but the adjusted was. When do you...
Okay, so when adjusted odds ratios take more independent variables into account in your logistic regression model. So the unadjusted would just be your exposure and outcome, whereas the adjusted would be the exposure and outcome accounting for the other variables in the model.
Okay, I got that. Questions on that? Does that make sense?
Mm-hmm.
All right, everybody's shaking their head like it makes sense.
Yes.
All right. All right. We'll just do 5 minutes on the toxidrome?
Sure. All right, so we'll just try to summarize it really quick. Let me just put the picture of the article up here. Toxidromes.
Toxicology day.
Yeah, this is actually a great review by Dr. Greg Ciatone.
Yeah, I like this too. I don't think there's been a good toxidrome chemical weapon review in the literature in the last couple of years. I like this.
Yeah, this was great, and it goes into great detail. But I'll just kind of summarize some of the main points that they made. Really, a lot of valid points. in 2016 alone, so many terrorist attacks globally. It doesn't, we see them every day in the news. You just don't think about it. Over 13,000, killing more than 34,000 people, chemical warfare agents. So I'm sure if we all go around the room and each name one, we could easily do it and name a separate one, right? Sarin attacks in Syria. What else? The VX gas assassination, right, with one of the Kim Jongs in Malaysia. And the Soviet attack, the UK, The Rock. That's a great movie, by the way. I think of that every time I read about nerve gases. So it's becoming, unfortunately, something that's increasing in frequency. We really have to know our toxidromes because, as they point out in this article, a lot of the times in mass casualty situations, you don't know what's going on until sometimes days later, right? Was it if there was a bomb and then there are multiple casualties? Was it a dirty bomb? Was there some other release of like a chemical or biological weapon into the atmosphere? So really important stuff going on here. I like the history. They go back all the way to 10,000 BC, and they talk about the rival tribes using different plants and animals to coat their spear tips before battle. Pretty cool. Actually, where I went to medical school, one of the things when you get in a machete fight, you drag it through poop so that when you cut your opponent's hand, they are guaranteed to get an infection. So that's biological warfare, right? You don't think about it, it's disgusting, but it's that kind of stuff happens all the time. We all think about World War I with chlorine gas, phosgene, sulfur mustards, all these devastating effects that are, in World War I, World War II. The Nazi regime developing all these chemical chambers. They developed sarin, talbin, soman, all these nerve gases that we really only read about in the textbooks until they happen in a large mass casualty incident. Definitely many things to consider in recent history and as well back to World War I, World War II. I think this is table 1. There are kind of several tables in the article that kind of broke it down into basically different ways to look at the toxidromes based on their class of agent, based on their agents that fit within that class, and then the last known use. And then another table kind of looks based on each individual toxidrome from that same perspective, if that makes sense. So table 1 shows all the classes, and I have to point out, so nerve agents, asphyxiants, so we're familiar with those. Hydrogen cyanide, that would be an asphyxiant. Anesthetics, antimuscarinics, vesicants, these are all things that could potentially be used. I'm going to pause here and just